Започваме сесиите на живо. Трите центъра, от които ще предаваме, са Света Ана, Пирогов и Национална кардиологична болница. Професор Сианос, един от хората, с които ще коментираме. И така. Дали ни чуват? Света Ана?
Чуваме ви, не знам дали ви чувате вие.
Чудесно, Васко, добро утро.
Добро утро на всички.
Разбрах, че сте готови.
Значи ние сме на етапа, в който сме хванали радиалния достъп, сложихме временния пейсмейкър. В момента, надявам се, това, което виждате на екрана, е контролната ангиография след пункцията на феморалната артерия.
А някой може ли да ни представи случая, Васко?
Да, разбира се. Сега ще ви представим случая. Джем?
Good morning, everyone, from St. Anna Hospital. I hope you can hear me well.
Very well.
So I'll present you the first case from our hospital for today. It's a TAVI case. So we have a 70-year-old female with dyspnea and fatigue on exertion, systolic ejection murmur on auscultation, mild peripheral edema, and stable hemodynamics. These are her lab results, normal hemoglobin, platelets, and creatinine of 94. This is her ECG, no LBB or RVB present. This is her echo. There is some concentric hypertrophy, no wall motion abnormalities, normal ejection fraction, and aortic gradient 79/52 with an aortic valve area of 0.72 square centimeters, mild to moderate AR. This is readings from the CT scan. So we have good heights of both coronary arteries. The important thing here is that she is with bicuspid type 1B aortic valve, moderate calcification. On the right side of the slide, you can see that we have chosen 26 size of the aortic valve with 14% oversize, but we're going to put 2 milliliters less, so that oversizing will be around 10%. These are the images from the CT scan. You can appreciate the bicuspid aortic valve. Fortunately, there is no big chunks of calcium visible in the LVOT and annulus. On the right side, you can see the intercommissural diameters. So our plan here is to pre-dilate with 23 balloon and then use the balloon expandable valve of Merrill, the newest generation, OctaPro. And lastly, here you can see the femoral arteries on both sides. There is some calcification, but they're of good size. So this is our patient, and now Dr. Velchev and Dr. Stoyanov can tell you about the next steps.
So we have a patient 70 years old. How to say, just fitting the new guidelines, with the only exception that it is a bicuspid aortic valve. Can you explain and discuss, the indications for TAVI?
Good morning, everyone. We extensively discussed this patient in our heart team meeting, and the pros for TAVI intervention was that the patient is quite obese, and fortunately she has really beautiful access, femoral and iliac arteries, and raphe is not so calcified without calcification extended to LVOT, and that's why we decided that it's quite low risk patient for a TAVI intervention, and we believe that we can succeed and to reach really good result, short and long term.
Yes, what we saw is really there are marked calcification. Yes, Vasco, sorry to interrupt you.
According to the European guidelines, everything above 70. According to American guidelines, we are discussing everything above 65. So in this lady, we have bicuspid, which is, we know, not a perfect anatomy for TAVI all the time. So we discussed it with our surgeons. Shall we go for open surgery, and because some comorbidities, and we decided that anatomy is very suitable for femoral TAVR. We will see how it will go with our approach. What we saw yesterday, the colleague from Turkey described beautifully all the problems with the sizing. We'll discuss it on the way, and our choice is balloon expandable valve. So we'll have some discussion about predilation, the perfect position, and so on. But for the time being, we're on the track to put a TAVI on this lady.
Yes. Usually, when we have a bicuspid valve, we have a raphe, but this is not calcified, and the calcification is not that extensive, which is good. The other options that we should discuss during in this situation, bicuspid valve, is which kind of valve should be selected, self-expandable or balloon expandable. And it is very important because self-expandable have a little bit higher risk of paravalvular leak, while with the balloon expandable, it should be very well precise because the risk of rupture is higher there. So you have gone for the balloon expandable. And what we usually need and what we usually do is to have, especially in a bicuspid valve, a very good predilation of the annulus, extensive, in order.
Valio, you see the calcification in the raphe on the screen. Actually, we don't have a trial comparing self-expandable and balloon expandable. We have only registries. As you notice, we are playing between two risks. Risk of paravalvular and risk of having a rupture. We think the risk of rupture is very low here. And paravalvular is something we don't want to have in a 71-year-old lady. So I think that balloon expandable is really the only choice here. Now we're trying to cross the valve, which is not always straightforward with bicuspid anatomy.
So we have Professor Tandafil with us too. And so we're in a process of trying to get through the valve. Just for the audience, these who are not well in this procedure, in the details of this procedure, we have you have a femoral access, which is necessary for the valve. What we saw from the CT, the vessels are quite good, acceptable. Probably they are the same as size. They are not that tortuous, and there is additional access, radio, right radio, and you can see the pigtail into the aortic root. And what we can see, this is the pacemaker. Again, it is venous pacemaker from femoral approach, because what is necessary and what is done usually, especially in predilation and during the putting the bone expandable valve, there should be a rapid pacing that will stabilize the valve during the inflation. Sometimes.
Vale, while we're crossing, can we poll the opinion of the panel in this situation? What would be your choice? Balloon expandable or self-expandable?
Yes, we are going to
Or maybe
do
surgery.
this. In my view and my experience, and it is in how I in a biased because our experience is much more with self-expandable valves, and probably I was going to go for a self-expandable valve. Professor Trendafil.
Hi, Vasco. I came late, so I don't. The assessment of ascending aorta, but what size of the valve will you put in these patients? What size?
The sizing.
30.
We have a valve which is a little bit oversized, it's 26 valve.
14,
So
30,
we are planning
13.8.
to
percent of-
inflate with minus 2 milliliters the balloon. So we are aiming in oversizing something between 5 and 10% for this situation, because we want to have the orifice well circular and open.
Okay.
So we go for 26.
In my point of view, I prefer self-expandable valves in these patients. If your patients is acceptable assessment for the size, but there is data from balloon expandable. And the patients who are suitable for balloon expandable are these with enlargement of the ascending aorta.
Here we don't have enlargement of ascending aorta, and
Yes.
in our experience we have quite good results in bicuspid anatomy with balloon expandable valves, and in the last few years there is in my mind switching between the self-expandable and balloon expandable, because in last 5 years probably the most operators they change their practice, and nowadays before that the self-expandable technology was preferred in bicuspid anatomy, but nowadays it's not the case.
So it looks like that the experience of the operator have more influence on the choice of the valve and not the bicuspid itself. Am I right? So you saw that we have a little bit of a problem crossing the valve. It's not always easy, but a simple poking and sooner or later we are crossing. So we are across the valve. We are planning to predilate with a 23 balloon. So we want to have the valve ready, and then we predilate, and after predilation we're going to position the valve a little bit higher compared to the normal tricuspid. So would you follow us, or you switch to the other labs? Now we continue with predilation.
And I would ask the panel, how do you choose for the diameter of balloon for predilatation?
In bicuspid valves,
Sounds like
balloon for predilatation should be on the minimal aortic annulus. If you
we
have a
decided
lot
to
of
follow
calcium into the left ventricle outflow, then
Be a
the
little
risk
bit
of
more
rupture
aggressive,
is
yes, that's-
higher.
rapid pacing.
What kind of
Okay,
balloon
we're
do
going
you?
to predilate now.
What kind of balloon is this? Semi-compliant?
It is semi-compliant, yes.
23?
23, stop pacing. Yeah, because the mean diameter is 24.6.
Welk pendel.
One of the concerns in bicuspid valve is the orthopathy, I mean dilation of
Right,
the
pacing.
aortic root. And the issue with this is, I mean with TAVI is if there is a diameter which is above 40, if I'm not mistaken, the data has shown that
Stop
even if you
pacing.
put the valve,
Full
usually
restore.
the aorta
Really?
continues to grow. That's why as an indication,
Yes.
probably one of the most important things is the diameter of ascending aorta. If it is less than 40, the results, we have the only issues of, let's say, achieving a good optimal post-TAVI results in terms of paravalvular leakage. And what will be your choice, Didi, for such a patient? Balloon or self-expandable?
Само удача погледна.
Balloon. I said I prefer self-expandable valves.
Self-expandable. Me too.
We
yes.
have two
Because
valves
you are very
dedicated
experienced.
for this patient. This is self-expandable of Medtronic and balloon expandable for Sapien.
Бай, дявол бе клапата. Дявол.
Трябва да е
Okay, we have a stable hemodynamics,
момент.
good pressure, so we're going now for exchanging the sheet. You know, it's a special sheet. If you want to put a MyVal, you need a special sheet which is kind of a
Expandable.
Python sheet.
Expandable sheet.
It's expandable. We are very closely watching on the wire while we are changing the sheet because we don't want any pop out of the wire outside the left ventricle. So the sheet is coming now.
Да видим долу.
Долу ли ще след?
It's very important to follow and to see when you put these devices, they're big in diameter, and you should follow, especially in calcified and tortuous arteries. And it's very, very important to stay on the safe side.
Can you say what is the size of the sheet? 14 French or 16?
Let's see the sheet. It's 14 French. Should change the sheet.
Yeah, but,
it is equivalent of 14 French.
Какво е?
We should change the sheet
Yeah, we shall change the sheet now.
because probably I broke the tip.
The sheet is supposed to be 14 French, but actually the hole is bigger
Yes.
because while you're going with the valve through the sheet, you are dilating the sheet, so you are dilating the hole a little bit.
Maybe here is interesting for the young colleagues.
Let's
In
put
this
the
type of
14
valve,
French sheet here.
They should keep the wire in the left ventricle because if you have
So while we are waiting for the new sheet, we are going back for our 14 French cook sheet. because it will take a few minutes to prepare the new sheet.
Is there any reason that you don't use this sheet from the beginning? Even during the balloon
Sorry?
predilatation?
Which one? The Python sheet, the expandable sheet?
Yes.
Because sometimes we have issues with the valve of the sheet. It was old generation of the sheet. Nowadays, the situation is much more stable. But we prefer to cross the valve, everything to be prepared, and after that to cross it with the
Because if you have a leakage from the sheet, it's comfortable to have blood coming from the femoral while we are waiting, and operator need to spend a lot of energy to compress the artery, which is not needed. Okay, we have a new sheet.
Usually, this depends on
coming
the
through
protocol,
valve and
Okay.
after that.
but the safety case in that situation, bicuspid valve, aggressive predilatation, I prefer to put the sheet advantly.
In advance.
And if we have unstable situation, you can do the procedure very, very fast. This is safety
Yeah.
procedure.
This is good suggestion, thank you. Now everything is fine. The sheet is going really easily into
Okay.
the arteries. Ne.
Okay, we are ready for the valve now. My valve have a special way to do something like a commissure alignment, but it's done while crimping the valve. Okay.
Okay, go.
So we are waiting to see how we are going to find an optimal position for the insertion of the valve. And after that, we are going to
Dobre,
move to our
spíval.
next center. This is National Heart Hospital, because that's very important, and it's one of the most important steps of the procedure.
Stop. Stop.
Vasco, can you explain for the auditorium? You should
Okay.
implant the valve higher. What are your markers? How will you proceed?
We have few markers on the system, but usually we are planning a really high implantation where we have a bicuspid anatomy. Our patient is in conscious sedation. That's why she feels some pain. Yeah.
You see that a valve is catching on the aortic
Okay,
valve,
okay, I think.
but we are through. Okay, aorto. So we want the marker to be on the annulus, the second marker which is inside the valve.
I think the position is,
Yes.
we have pressure down as usual, but we probably want a higher position now.
Will you implant in two
We are
steps
adjusting the marker.
inflation or one? Two-step inflation or one?
Valve по-високо. One. Okay.
Okay,
Нещо такова.
okay, rapid pacing.
Клапата идва.
1, 2, 3, 4, 5. Okay, now stop pacing. Uczęszcz tu. Nešto ne je narad. Ne, zahvana tako. Okay. Okay, we aim this really high implantation because of the higher risk in bicuspid anatomy for permanent pacemaker. And as Professor Vasilev said yesterday during the sessions, this is kind of different animal, the bicuspid valve.
Пиктайл ще ни трябва сега.
That's why our protocol is usually to predilate aggressively, high implantation, and if we need, in really calcified anatomy, post-dilatation. But the valve looks quite well expanded, and now we will see what's the result.
Can you see the hemodynamic?
Yeah, just to have
You don't see.
correct zeros and to flush the system. The wire. Удача.
Удача. So first we are going to release the pigtail, which is kind of jammed by the valve, and then we are taking the hemodynamics.
Usually it is recommended to remove the pigtail before implantation,
Yes.
especially with bone expandable, but I have seen doing it without any issues, as we can see here.
But nice. Okay. 0. Once again, please. Good.
Okay, that's the hemo. Do you see the pressures on the screen?
Not clear.
Not very well, but what we can see that they overlap, and I think there is no gradient. Correct me, because it's a little bit. And now it's very well seen.
Yes. And
Yes.
Yes, I
we
don't
see
like
in TCG of the patient there is
diastolic
no.
pressure too much, but
Yes. There is no gradient. Let's see where we have aortic
The
regurgitation.
diastolic pressure is also quite low.
But maybe
It's around 100, so
the incisors.
now we're going to do
Orthopedic.
an angio for you. Малко назад.
Maybe you have bigger insufficiency.
As you notice, this kind of anatomy is like we have the same parameters for the. We have same diameter for outflow tract and for the
Excellent.
annulus, so it's not a conus, it's something like a cylinder.
Really spectacular result. No aortic regurgitation, no gradient. Congratulations.
That was the idea behind our strategy, that we can offer such a young patient with bicuspid anatomy that in general it's a challenge to deal with our technology, because we strongly believe in selected cases like this one that we can have this really good result. I believe long-term result is going to be also really good.
That's
So
great.
You may notice that even
I
if
have a
we
question.
wanted to put it,
What will be your antiplatelet therapy in this patient? Intraannular system, balloon expandable system, young patient. What is the treatment
sorry,
of the...
Professor Tadafel, what's the question?
The question is, what would be antiplatelet treatment?
Antiplatelet treatment.
Yes,
Clopidogrel only.
We believe in single antiplatelet agent. So usually we put the patient on clopidogrel.
only
And
clopidogrel.
of course we follow the gradient. If the gradient is okay, we keep in, and if we have early increased the gradient, we switch to the anticoagulation. But most of the time we stick to the clopidogrel as a single antiplatelet after the
We're going to
implantation
move
of,
to the next
IMO.
CAD lab, and we're coming back to you because they're ready and the patient is, let's say, in an advanced
Okay, Valo, we
part
are
of the
closing
procedure. Maybe we can come and discuss for a while some other details. So, I can see the guys. Can you hear us? Sasho,
Yes.
Yes, yes.
Yes. Hello.
Lubo. So, you can,
Yes, I hear you. Hello, Sianos. Hello, Valery.
and Professor Trandafilova is with us.
Yeah, okay.
So,
Okay.
okay,
We can
please
We can see you.
present the case.
we can't see you. We can present the case, Dr. Peneva.
We're going to present you a case of an adult with a congenital heart disease. This is a 25-year-old patient with a repaired tetralogy of Fallot with the following history. At 1 year and 6 months, he had a transannular patch repair with VSD closure. At 12 years of age, due to high-grade pulmonary insufficiency, he underwent his second heart surgery, pulmonary valve replacement. And in the following years, at 18 years of age, he had third heart surgery due to the degeneration of his pulmonary bioprosthetic valves. And he underwent re-PVR with Medtronic-Hancock of size 23. In the following years, in 2023 and 2025, he underwent 2 cavatricular isthmus ablation for symptomatic atrial flutter. The patient has been symptomatic for chronic heart failure, second-grade class, according to the New York Heart Classification, which is clearly demonstrated with his extremely elevated NT-proBNP of around 280,000. Due to multimodality imaging diagnostic, we concluded that his current hemodynamic problem could be attributed to degeneration of his second pulmonary valve bioprosthesis, and this is clearly demonstrated by the ECHO criteria. He has gradient at the level of his pulmonary valve evidence with 60 to 23 millimeters of mercury. He has right ventricular dysfunction, which is dilated with a TAPSE of 13, and he has elevated right ventricle systolic pressure around 70. Further, on the next slide, you can view the images of the CT reconstruction of the pulmonary valve and the right ventricular outflow tract. The following measurements could be further used for appropriate valve selection. Based on the clinical data, on the hemodynamic study and the multimodality imaging, his previous 3 heart surgeries, high surgical risk, and most importantly, the reluctance of the patient to go further with 4th heart surgery, we decided to move on with a transcatheter pulmonary valve replacement.
Ние може ли ги виждаме?
So,
Valerie, is possible to see you?
I don't know.
Yeah, okay.
Yeah, okay, perfect.
Okay.
So please just explain the setup with you.
Um, for the pulmonary, we have to have arterial access and a pigtail in the aorta, because even though it's a valve, we should perform a test to be sure that no obstruction of the coronaries could happen when we put the TAVI valve. So we have a pigtail through the right radial in the ascending aorta. We have left femoral for vein for a pacemaker, and right femoral vein for balloon and valve delivery. If you can you see the angio that we
Yes,
are
yes, very well.
rolling? Yeah, so we did cross the valve with the pigtail to be sure that we are nowhere under a leaflets or somewhere parallel to the valve. You see that it was not very easy, but finally we could cross.
Sasho, sometimes superior venous approach is easier for this position.
Yeah, you're right. I agree with that. But we have all the pulmonary valves we have done are from femoral approach, and we haven't done it from superior vein. So we feel safer to do it from the. We did cross eventually, and we did put Landerquist wire deep into the right pulmonary artery.
This is
Okay,
very deep.
then yeah, it has to be very deep, because now we have to advance a 24 French dry sheet, a dry seal by Gore. So we have to have a really
Yes.
good support. It's not very easy to advance a 24
You are going
French
to
sheet.
direct implantation or will do pre-dilatation?
We did
Ah,
a
no.
dilatation, not with the intention to pre-dilate the valve, but to assess the coronaries. There is the dilatation. This is the so-called barrel view. Like you have to see the balloon as a barrel of a pistol, and then you make an angiography, and all parts of the coronaries should be at least 3 millimeters away from the balloon. That's how you're sure that when you put the valve, there is no risk of coronary compression and
Yes,
obstruction.
that's right.
So, because the balloon jumped a little bit, we are pretty much sure that there is no risk for the coronary arteries. And we made the second dilatation of the valve, and yeah, that's the dilatation. So we are at this stage.
Okay.
Any comments, suggestions?
No?
It is a quite, at least for me, probably for a bigger part of the audience, I mean, this procedure, especially in these patients with congenital heart diseases. So it seems that you are, how to say, we're waiting for you to put the valve. Probably you should, I mean, you should comment and tell us more about this procedure and how many patients you have done it.
Okay, the first doubts that we have were...
What I'm going to say for the audience is that this is, the team is, how to say, composed by interventional cardiologists, pediatric, and for adult, and probably this is something that should be noticed. So we are hearing, waiting for you to have your comments.
Okay, first we had doubts whether this patient should even get a percutaneous valve, because he has a Hancock prosthesis which is not fracturable, so we cannot expand the surgical bioprosthesis. And the internal diameter is 19. 19. So we have to put a smaller valve that he initially has. This is an issue about the durability of the valve that we are going to put. We don't know really how long it's going to last and whether this patient would not need a second TAVI in 10 or 12 years. But since the patient has already 3 cardiac operations and he doesn't want a 4th one, we decided that we should risk and put the TAVI valve. Lugo?
Yep. Everything is clear.
The second big issue with the pulmonary is that, not as in aortic TAVI, you can go directly with the valve. Of course, you can try, but there are some anatomical curves of the right ventricle which are not very easy for the valve to take. That's why we have to put a sheet beyond the surgical bioprosthesis and advance the valve through the sheet, then retract the sheet, and then implant the valve. So now we, the hardest part is to go with the sheet beyond the pulmonary valve. This is the hardest part of the procedure. And so now this is what we are going to do, okay?
What was the size of the balloon that you did the predilation? It was a 19?
A 20 balloon.
20.
A 20 by 40 balloon.
20. And the valve? And the
going to
TAVI
be
will
20.
be?
20.
20 also.
Yeah.
Do you use a non-compliant balloon or semi-compliant?
Semi-compliant balloon, because
Maybe
the valve...
sometimes non-compliant should be preferable.
But the Hancock prosthesis is not either fracturable nor you can dilate it, expand it. You cannot do anything to a Hancock prosthesis. So no matter what we inflate, it's going to stay, the ring is going to stay the same.
You are going to implant Sapien, not Melody.
Sapien, yeah. Okay. Da. Dilatator. We're using this
Do you measure any hemodynamics before all of these? During, or it's not
We
necessary?
have,
You're completely based on the echo?
We have the hemodynamics from a previous invasive procedure, so we didn't measure them today, but we have it if you want them.
No, we're going to see afterwards. So I'm just asking what is the routine procedure.
So this is a dilator. We are just going to leave it for a little bit to expand the skin and the vein. It's from 5 to 24 French regarding how deep it goes.
Mhm.
Да вадим, а? Vai.
For the audience, sometimes it's very difficult to go with the sheet in the exact position. So sometimes we need to use body wear in,
Yeah,
this, in
sometimes,
this
like-
anatomy. So you are going very easy
Until now.
Yeah, no.
until now, yes. Here is the problem.
And the size of the sheet is
24.
24.
Какво? Ага. Може да го завъртиш малко? Да. Сними го дъче. Добре. Да, нека я направи тази кривка. So I think we should use a balloon to try to track it. Извади дилататор. Вайската, да. Влади, Любчо. Не минава.
Да отидем going to leave you at this
Okay.
point, and we are going to move to Pirogov. Just
Okay.
if you, advancing the procedure, please record the steps because it seems very interesting. But the colleagues from Pirogov are ready. A very nice picture.
Yeah, glad this. Hello.
Very nice picture of your department. Excellent. Dr. Martinov.
Yeah, it's not so sunny today, but it's sunny here. I'm with my colleagues, and we will present you the case, coronary case for IVL. We made some angio and measurements. I will show you the case first.
Okay, present the
My
case,
colleague
please.
will show you, will present, yeah.
Hello, we have a 83-year-old gentleman with a history of hypertension, atrial fibrillation, and moderate to reduced kidney function. We did some echo before the procedure, which shows moderately reduced systolic function, GLS minus 11%, and moderate mitral regurgitation. He has history of acute myocardial infarction several months prior with 3 stents of the RCA. Last month we did a PCI of the LAD, which was done with 2 stents. The patient actually has also 50% stenosis of the left main, as well as aneurysm of the proximal circ. He has also very severe carcinosis, which is shown here in the CT scan, which we did before the procedure. You see the 2 stents here in the LAD, as well as the very severe circumferential calcinosis of the left main and the LAD. This is the IVUS, which we did actually the last procedure. Our probe couldn't advance in the LAD, so we did only on the circ and the left main, but you see the calcinosis as well as the stenosis here. This is the circ, which is actually patent. Okay, so this is our case.
Now I can show you the today's angio. What we made so far. This case is an example that the complex procedures cannot be solved only with angio. You see that the calcium, it's not so visible on angio, but you saw the other modalities that, especially CCTA, you saw a lot of calcium from left main to LAD. You can see now the previous stents in LAD and the narrowing of distal left main, and the ostium LAD is not so visible here, but you see, sorry. Yeah, the narrowing of left main distal stenosis, and the aim is to crack the calcium with shockwave balloon. Till now we managed to crack the IVL, but not calcium. Now we will start with the procedure. Any questions?
You did shockwave yet or no?
No.
Your strategy is to use shockwave balloon.
Yeah, to crack the osteoproximal segment of LAD and distal left main, and perform after that IVUS to see the result, the cracking of calcium. And I think the provisional stenting is feasible here, and maybe that will be the procedure. But the focus is on
can we see
severe
by
calcium.
the projection? Because there is an aneurysm in the circ.
Yes, this is the tricky moment when we are discussing this aneurysm is originating from LC Hicks. That's why it's close, but it's feasible to use shockwave here, because it's not on the segment with aneurysm. We are using it for proximal LAD and left main distal.
You have an 8 French guiding, I see. Am I correct?
No, 7 French.
It is 7
radial
French.
approach.
Radial.
Yeah.
The MLA was 6 point something, correct? At the ostium of the LAD.
Yes.
Theoretically, this should be enough. It's not 3, it's not 2. I don't know if the patient is still symptomatic, but did you consider doing kind of physiology imaging, let's say an FFR or something like that, as a justification for an intervention of the left main with calcification? Because 6 point plus for the ostium of the lady might be acceptable. Is he symptomatic?
Yeah, that's... today's measurement is 5.6 today's because it's very eccentric. The IVUS couldn't pass without predilatation with non-compliant balloon.
Okay.
That's why we are convinced that we should open the segment, crack the calcium, and put the appropriate stent about 3.5 and pot of left main.
That's very good. So you wire the vessels as we see.
Yeah,
And
we have wires and
so at this stage
the
you have
short-
done a predilation with an NC balloon, correct?
yes,
Okay.
the small one, 2.5, because
Okay.
we must perform pre-IVUS, pre-procedural IVUS to
And it crossed
compare
easily. There was no issue of
after.
crossing with the NC.
Yeah,
Very nice.
no issue, but as the probe was problematic to cross, and we managed to open with the 2.5, and now we are ready for AVL procedure, and after that we will perform IVUS after cracking to see the difference. Now we can show you the previous IVUS. I don't know if it's
We don't see.
visible.
Ah, yes.
No, трябва да се обърнем малко. You see the concentric 360 degrees calcium on that segment. This is ostial LAD, but you see the eccentric
Is it calcified now then?
calcium nodule here in more distally. This is after the stents, I mean in the pullback, after the stents, the segment, you see a lot of calcium and eccentric nodules, which prevents the movement of probe. And you see the jump here from here to here. And this is the tightest segment. You saw it on CCTA image. That's why we think that the problematic segment is here, osteoproximal LAD. And we will compare this image with, you see in the left main there's again 180% degree calcium, eccentric, but in this osteoproximal segment is the tightest and the concentric calcium segment. And as I mentioned, it's far from the aneurysmatic segment in circumflex. If you don't have other suggestions to open the proximal LAD and distal left main.
Yes, please proceed. What kind of balloon for the IVL you chose?
IVL 3.5.
Okay.
And we will perform. maybe in especially in this segment, but some. Okay.
Can we have the angio on the big screen, please? Yeah, thank you.
It was very easy to pass because it's a bulky device, and we are not sure to without predilatation to pass through this tight lesion. Okay. We are starting here. What do you think? Maybe here and about 30 shocks, and then 40 shocks, and then in the osteoproximal part, maybe 30 shocks again.
Okay. Let's see how the patient will tolerate this, because
yeah, that's the.
I mean, especially in the left main.
We will not insist to have all the shocks. I'm starting here.
So just for an information, the shockwave balloon, the balloon is inflated, it is connected to the system. The balloon is inflated up to 4 atmospheres, and after that, the therapy is starting. I mean, therapy, that means that during this period of therapy, which is these 10 shocks delivered, in the balloon there are emitters, and from these emitters a spark is induced there, and this spark makes bubbles, and this opening and expanding and continuous several expanding at a very high rate, and after that infusion of the liquid in the bone produces these acoustic waves, which can induce a pressure around 50 atmospheres. And these acoustic waves, they travel all around, and in fact they affect the calcium, the superficial and the deep calcium. And that's why one session is done of 10 impulses. Did you inflate the balloon?
Yeah, I inflated to 6, deflated to 0, and now I'm inflated it again to 4 atmospheres, and starting the same.
The second session.
But
we cannot see this shocks on the screen. I mean, the inflation of the bone, it's not seen.
Yeah, sorry. Here it is.
After this series of 10 pulses is done, the balloon is inflated up to 6 atmospheres, and the procedure is produced. That's why there is a period of at least 10 to 15, 20 seconds for the treatment, one treatment period, which in some cases is the left main can be an issue.
Как си? Добре ли? Okay. The patient is asymptomatic till now. I'm moving proximally and inflating to 4 atmospheres.
So in total with the same balloon we can give up to 10 sessions. as Dr. Gelev says.
Yeah.
Each session is 10
Yeah, but-
pulses, and you can see them. So, and these are all automatic. So there is a button. You see in the right hand of the operator, he has the button that he is activating the pulses. And can you show us the ECG when you're you see that he's pressing it and he's activating the IVL, as Dr.
ECG.
Gelev explained. And when you see on the screen on the
Yeah, maybe
ECG, you see kind of spikes of like as a pacemaker. 6 atmospheres and down. And this can be
Yeah.
repeated with the same balloon up to 10 times. Afterwards, as a kind of a safety. Yeah, leave it there, and when you activate, we will see the spikes of the application of the device.
Yeah.
When you do the next session, just leave it there so the audience can see how it looks like the ECG when you're applying. Patient looks very stable,
Yeah.
which is important. That means that the ejection fraction is, yeah, you see it. You see like a kind of a pacemaker thing, these red lines.
Yes.
This one I don't know. If you have a
Yes.
pacemaker, it
No,
interferes.
not with the pacemaker, but it
You
can
saw the spikes?
interfere and make the contraction of the
Ah.
of the heart.
Ah,
But that's
okay.
very rare, with without any consequences.
Yes.
And what we can see clearly here, the ballooning is spanning quite well.
Yes.
So probably it is working. It is very spectacular to see a lesion which is really very tough, and you have the typical dog bone effect on it. And when you put the bone, just after you can see with each impulses, waist of the bone is expanded fully.
Yes, that is the more spectacular part of it. Of course, here the balloon is expanding in advance. And you show, this is better now what you were saying, Dr. Gelev. You see that there is a waist, a little bit in the balloon. Now you see the application, the red lines in the ECG. That means that the operator is activating the machine. It's stopped now. 4 to 6 atmospheres.
I'm
you can see
deflating.
the inflation. And what was very interesting is that you saw that when you're inflating the balloon, it's losing its profile. So whenever it was retracted a little bit more proximal, there was some resistance. So this is something, it's a balloon that doesn't have a very good secondary profile. It's rather bulky. You can appreciate here the resistance to pull back the balloon. But the shock waving will help that.
Yeah. I'm applying the next shock a little bit proximal.
What is the number of this now?
Here is the balloon.
Yeah, it looks well expanded. That means that it is effective. In this position, there is a little bit of wasting. Once someone should consider this is
Yeah.
your 5th application, I believe, correct?
Yeah.
Maybe 6. During the 6th.
6.
Fif-
So
six-
you have to be careful that you have enough applications from the same balloon to reach the left main, and because otherwise it will
I think
be.
that's maybe enough for this patient because the waist is very small here. And
We're
other
going to move for a
consideration
while
is-
to St. Anna just to finish the case.
Okay.
And after that, probably in the National Heart Hospital, because they're ready to put the valve. So you have enough time to prepare, and we're coming back after a couple of minutes with you. Виждаме ви, чуваме ви. Вие сте готови.
Yep, we've finished the case. The lady is already in the ICU. So we want just to share a few words with you. You saw it's feasible to put a bone expandable bicuspid anatomy. This valve is a new iteration of the octacore valve. It's a little bit different structure compared to the original MyValve. And you see we have a marker which is more closely to the distal marker, and it should be positioned exactly at the annulus. So it kind of gives an idea, because foreshortening is very low, in this valve, so we almost don't have any foreshortening. And well, we position the marker. Then we have a little bit interplay. We wanted to orient the valve to be coaxial with the aorta. And this valve have a special knob, and you can play with the angulation. And we use this very often when we have to pass the valve. We change the angulation a little bit. And then it's very quick as any balloon expandable. You see it's different from the original My Valve. You have only two rows of diamonds. And we think that it's an optimal positioning. It's not too low, it's not too high, so the patient don't have any conduction disturbances. And we plan to take her home in 2 days, maybe.
And what
So
was
do you have any
the closure?
question about the procedure?
How did you close the access site?
We use a suture-based device, ProStyle. We did one per close at the beginning of the procedure, and we had a really minor bleeding. But to secure the situation, we put one small plug-based device, Angio-Seal 8 French, and we finished really fast. Because this is our regular protocol for everyday practice.
That's a default, and we don't check with an angio. We're just looking for the pulsation. We are looking at the echo. We are checking the Doppler signal, and everything's fine. We are finished.
Thanks.
So that's
Congratulations.
it from us.
Congratulations.
Congratulations.
We used
Really
27
very good
millimeters of concrete.
job done in a very short period of time. And I just wanted to share that in the National Heart Hospital, they are doing again a structural procedure. They are putting a valve into the pulmonary artery, and this is finally reflecting the trend of interventional cardiology. That in this session, from 2 centers, 2 structural interventions and 1 extremely calcified. So thank you. See you later.
Okay, thank you.
Let's move to the National Heart Hospital. We are with you.
Okay.
We are ready.
Hi, can you hear us?
Yes.
So we finally managed to cross, yeah.
Yes, but
But we used a balloon, tracking with a balloon. So that was the only way we could cross the valve, and it was not really that easy also. But with a little bit of pushing and pulling and inflation and deflation of the 20 balloon, we were able to cross, okay?
sometimes this maneuver is very useful.
Here you see that the sheet has crossed, but we wanted to put a little bit deeper, so that when we advance the valve, we are sure that it doesn't pop out into the right ventricle. So we advanced it a little bit deeper inside the pulmonary artery. And then, you know that SAPIEN, the valve is crimped, and then you have to align the valve onto the balloon inside the patient. When you do the pulmonary procedures and use that sheet, we do this alignment under X-ray, but outside the patient. So it's a kind of different approach for aligning the valve to the balloon. You see the markers of the balloon that are aligned with the end of the SAPIEN valve. And this is the valve coming Това няма да го показвам. This is the valve coming outside the sheet, and this is the we retract the sheet. Just a second, because I lost track of the scenes. Yeah, okay. And this is the positioning of the valve.
Did you use pacing or no?
Yes, it's on rapid pacing, and this is the implantation. Okay, and now we are going to do angio to see if there is any regurgitation. Okay.
Okay.
Check.
Да.
And
така.
please, the microphone activate.
Това е
this
в камерата. Това е.
В коя проекция искате ортографията?
В профил.
В профил.
There is a question about the resting gradient.
After pulmonary.
Ще пръскаме. О, готови сме. Хайде. Дълбоко.
Светни, молете се.
Стига, че ще ми швеците. Гога? Айде.
Okay, so no insufficiency.
What is the gradient?
We have to see now. We don't know.
Гога, промий тук. Напред. Добре. Айде тук.
Чакай да вземе хубави.
Нули ще вземем?
Да, ще вземем.
Айде нули и на двете май.
Така ли? So there is a residual gradient. It's 15, the mean. But
It's not bad.
It was 50 or 63 before the procedure. Yes?
yeah. So it's reduced by half.
This is acceptable gradient for me. Well,
Yeah, for
Yes.
pulmonary, that's
for the pulmonary, but in this situation,
I'm wondering if we should try to do some post dilation, but I don't think it's going to help. And there is a risk of damaging the leaflets of the sapiens. So what do you think about post dilation?
It looks like that you don't have any aortic regurgitation, any valvular
No.
regurgitation, which is a critical point. So essentially, this was also part of the pathology there. And below 20, I think it's acceptable. And as you said, I mean, the valve is not also the surgical valve is not crackable. So I don't know if you will achieve much more worthwhile to
Yeah.
pursue an aggressive post-dilatation. I don't know. What do you think, Dr. Gelef?
As far as I saw in one of the projections, the valve is well expanded. And so we have the
Yeah.
limitation of the previous valve. So I don't think that we are going to achieve that much more. This is something what we have seen in some patients with putting in the aortic position in a previously operated, I mean in a previously implanted valves, and you can reach the limit of the valve and you cannot go further. And any other intervention can bring you only the risk of the procedure, let's say, of the intervention. But you're the guys to decide because you're the most experienced as far as I can see here, with the exception of some people to the left of mine. I mean the other part of the interventional cardiologist, the pediatric.
You think the gradient is acceptable and the
Yeah,
result is...
absolutely acceptable.
I'm not sure if you decide to do post-dilation, we will decrease the creatinine, because I think that the results is very good for this situation.
Okay,
Excellent
congratulations.
procedure in very complex
Okay.
anatomy.
That's really
Thank
very
you.
complex and unusual
Thanks.
for us. Congratulations to the team. We're moving to the Pirogov.
Дайте сега да извадим.
Може би после.
So, Ivane, we are with you again.
Hello again. We performed additional two series of 10 shocks because the IVUS catheter again couldn't pass because of these nodules. And after that, without additional predilatation, we managed to perform IVUS, and on the screen I put the cracked calcium of this circumferent zone, which maybe if you don't remember, I can find the image, but it's obvious that at least 5 points of cracking here, and I think the result is
We can
very
see one
good.
big
I don't
one
know
at
you.
9 o'clock, the other one is between 11 and 12, am I right?
Yeah, on 3 and maybe on 5 o'clock. Some partial cracking, but at 9 is obvious, more obvious.
And you went with a non-compliant wound after that, or this is only the result of the shock wave?
This is only shockwave. I'm trying to convince you and and myself of effect, and I think it's very demonstrative.
So I think we are all
Do you think
convinced-
that
Yes, absolutely.
we should predilatate now with NC balloon or direct stenting and post-dilatation?
Sure, it's my opinion. You go for a non-compliant bone. And usually, this is what is recommended because this bone it has its effect, but still the pressure at which you inflate it is very low, and the bone is semi-compliant. Probably will be much more easier for you to pass the devices after that if you predilate intensively with non-compliant bones. George?
Yeah, I fully agree, and I know some people also prefer to do scoring or cutting balloon post-dilatation to complete, and based on that, it's not only achieving potentially better cracking, but it will give you an indication of full expansion. For instance, if you go into that direction and you see that your balloon is not fully expanded, then you know that the stent might not be. So I believe that, in my view, and that's our standard practice, is that we do a post-dilatation with any device post-IVL. Dr. Trentafilova, what is your opinion?
Me too. I prefer to post dilate in this situation. Maybe scoring balloon is better than NC.
It's better.
I
I'm
think-
prepared to NC balloon. That's why I'm not trying to go.
I think
Other direction.
any additional predilatation with either it's going to be
Yeah.
sufficient, because definitely in the IVUS is obvious. But as far as you are planning to do a 3.5 stent, we want the main thing is that 1:1 based on the stent size with an NC balloon before. So
1:1 ratio, 3.5 by 12.
yeah, whatever
is
you
coming here.
the length is not it's okay, but I think this will give you a very good feeling of the expansion. If we can see the angio in a big screen, it would be nice. So
Yeah.
you have a 3.5 NC over there now.
Yeah.
Yeah. Okay. Yeah. It looks like it's a very good expansion.
The
No
vessel
waste
is,
here.
what I can see from the IVUS, the vessel woman to woman is at least 3.5, so you can go easily. I mean, safely with 3.5.
You see here maybe additional inflation, but almost no waste here. You remember this was the place with the biggest waste of the IVL balloon. But with this non-compliant balloon, we achieved, maybe this is the result.
Even at the left main level, you have a very nice angiographic outcome. Doesn't look also like dissected.
No, it has the typical appearance of using
Yeah,
IVL.
we-
There is small dissection, but which is in the vessel. I mean, not dissected plane of endothelium, but just cracks in
Дай
the
главата
vessel.
налево. Okay. We'll see it on the right cranial. Sorry. It's not so good projection, maybe this is okay. Almost no dissection here.
No, it is no dissection. Usually when you go with the IVL, you can see something as nabobvane at the vessel side, but that's great. I think it is almost stent-like result, but I will not appeal for drug-eluting balloons. I would put a stent.
Absolutely. Change the strategy.
Yeah, especially calcified lesion.
Sometimes.
Maybe stent is the first choice. No doubt for
That
me.
was a joke. I mean,
In this
not joke,
case.
but some people are going to
I was
accept
going to
it
ask
very
about that. I was going to ask about that, but you fulfilled the anticipation of the case. Also, the LAD is a little bit, the ostium of the LAD, if we see it even geographically, the ostium of the LAD is a little bit hazy.
Yeah, there is a little something
So
here.
in that respect,
We are ready with this long-weighted stent.
yes. What I'm trying to say is that it is left main. There are no clear guidelines. So we have to follow the traditional guidelines and make sure that case safety, but the result of the lesion preparation for calcium modification is an excellent example. And another comment that I would like to make here is that that this is a typical case that there is a preserved lumen before the calcification. It was around 3.4. And these are the cases that essentially you don't need to have additional rotablation or any other. If it was a very, very tight stenosis, this would have necessitated potentially before IVL to do some rotablation. But that's a typical case that you have a rather preserved lumen that essentially a bar of even 1.5 or even 1.75 might not make a difference.
It's not going to be that effective, but still, if there is an issue passing with the IVL balloon, which is usually the case, and it is recommended to go with at least with a balloon before that. And if the balloon is not passing very easily, I was going to go for rotablation. Yeah. And what we saw here on the IVUS before that, we can see some areas in which the wire and the IVUS is coming very close to the very calcified zones. So in this situation, we don't have this wire bias, and probably the rotablation will do its work.
Yes.
To some places, in some part of the calcium, it will go and ablate the calcium until we make it much more easy. But it works there, and there is something which is very important with rotablation. In my experience, if you go with the rotablation, all the devices after that are going very smoothly.
Yes.
And this is something very important. It's not here, for example, but if you go distally in this extreme calcification, probably rotablation will pave you the way to
facilitation of
facilitation. Yes, that's providing you. Yes, the.
Exactly.
How long is the stent and what kind of stent? Ivane?
It's Xans 3.5 38.
38.
I think that's
It's
okay.
Yes.
I don't know, do you see the stent boost on the screen?
Yes.
Maybe it's useful,
It's
especially in
a
that
good
situation.
position. What I'm going to do, if I have to do it, is I will go a little bit distally, just to, because the ostium of the left main is not diseased. It's a big one. As a position, it is what it should be, but having in mind that in some cases you have to do PCI. If you are protruding too much, that will make your wife much more harder in the future. That's a comment.
I had the same feeling also. We'll go a couple of millimeters, not much, but that's
exactly.
better. That's better.
Maybe
position.
it's better.
Yes.
That's better position, and
there's a little trumpeting here of the left main.
Essentially, you respect the ostium.
That's why.
The good thing about this left main is that the upper and the lower rim is quite close to each other, so there is no big discrepancy. There are other left mains based on the takeoff that you might find a bigger discrepancy between the upper and the lower rim. This was not the case.
This is what they describe as asymmetrical appearance of the left main.
Exactly.
And it is usually that the roof, let's say here, is much more.
Yes. And I believe also, I don't like, except if you have really ostial left main stenosis to protrude, not only about the accessibility of the future interventions, which is a very important thing, but there is always a risk that during the acute intervention, you really, by engaging and disengaging and post-dilatation, that you might disturb the
longitudinal
the longitudinal
restoration of the stent.
So it's better if you.
And what we noticed that the balloon expanded very well.
Yes.
The balloon of the stent. And a note that I wanted to discuss, using divers facilitate us and makes our let's say, wife much easier because we saw that the circumflex ostium is quite big, and we don't have any issues of pinching of the ostium after the putting of the stent, and this is something which is very important too.
Yeah, this is the one part of the discussion, what to do for the circ, because it's a relatively small vessel. But what do you think about the kissing here?
I think, first of all, you have Dimitri flow, which is the most important thing. And you have to do a good pot, just with a 4-row balloon in the left main, potentially.
Yes.
And if we see a caudal projection or a spider, we'll give a better. The nice thing about this circumflex is that if you see the anatomy, the angulation between the circumflex and the left main is more than 70 degrees. It's more perpendicular, which makes the possibility of a carina shift less important. So with the absence of any stenosis into the ostium of the circ and any carina shift, personally I wouldn't be, it's very easy to do, but I don't know, there are people that they have a preference. There are some OCT data that they're showing that you have on the stent some formation of material. Some people like the predilatation, some others not. I think that you should predilate a little bit more the left main and give us a better imaging, because we don't see clearly here. We're more selective if you take a 4-row balloon high pressure. It will allow you to engage with the catheter deeper, and then we will have a more clear image. What I would have done personally at this time point, I would have removed the wire from the circumflex. And anyway, even if you do need to do a kind of a post-dilatation, the vessel is safe. There is no any big issue there. You can rewire it. I don't really like to trap the wires, especially in calcified vessels with high pressures. I don't know if anyone has a different opinion.
I fully agree.
But first we should use pot balloon in the left main and then decide, or now to remove, is your point. Now to remove the wire.
Earlier. Before pot.
Because there is ostial left main stenting, sometimes when you remove the wire, you might have a reaction of the guiding that might dive in. And the wire is absolutely underneath the strut stents, so the ostium of the left main stent might be distorted. As far as you have Dimitri flow and you're going to do pot, which means that you're not going to overlap again the circumflex, it's quite safe to remove the wire, in my view, because in this specific case you don't have concerns about losing the circumflex. And of course you will not use this wire for any intervention. So personally I would have removed it, except if you want to do a crossover and dilate over the ostium of the circumflex. But that's my personal preference, and specific for this patient. It's not any kind of an consideration that I have 4 cases. It's always anatomy dictated. You can make maybe the projection here if you engage a little bit deeper with the guiding, so we can see the ostium better. If you push the guiding a little bit deeper and you give us a good injection, we will understand the ostium of the circumflex better. Yeah, that's much better now. Looks very good, I believe, to remove the wire. I wouldn't hesitate in this case to, and I do believe that also, you have also this aneurysmatic part over there. That in this specific case, I don't see any consideration of removing wire and doing any kind of post-dilatation. And I don't believe that the wire in the circ will be of any help here. I don't know what Gergiev.
But it's good to have balloon here, not to try to avoid crushing the stent with the catheter. I'm putting it and removing the wire.
very easily. It went very easily. That means that
Yeah.
the left main needs more post dilatation. Of course, it's
Maybe more bigger balloon, I mean.
yeah, 4.0 is yeah, you go half a millimeter more, and then you have also the IVUS to confirm about the ostium, because for the ostium you might need to go to 4.5. You have the imaging, which I think is important in this case
Yeah.
to do imaging-based post-dilatation.
Изчитам, бе.
If I have to do it, I probably go for a kissing balloon, and this is our practice, especially for the left main, because as you mentioned, some studies, imaging studies, said that if there are struts that are covering the ostium of the circ, some processes are going there, and they can lead, in some cases, to occlusion of the vessel.
I have also the same policy, to be honest. Simply, I'm just saying that, and usually, whenever there is no compromise of the ostium, as in this case, I tend to do it a little bit undersized. So, in my view, I would have gone with a kind of a 2.5 balloon in the circumflex, not bigger than that. Even to just you create a little bit of an ostium. It will not improve the flow, but it will make a better access to the circumflex. You don't want to dissect the circumflex. That's what we mean. So, because bifurcation standing in this setting would have been a...
There is an aneurysmatic parac there, so we should be careful. Yeah.
Yeah, 2 or 2.5, so a little bit undersized whenever there is no carine shift or there is no flag.
Yeah, тук или в... Okay, we performed post-dilatation with 412 balloon, and now I'm performing stent boost. My colleagues will show you the screen.
In these kind of cases, I prefer to flare a little bit. So you more or less cover the ostium in a nice way. And
yeah, we are preparing the bigger balloon for the
so
ostium.
the stent boosting, especially for the
4.5.
ostium, the stent boosting for the ostium of the left main is, yeah, okay. You're talking about the pod, yes.
4.5.
Yes, very nice.
4.5 pod balloon for the ostium to flare.
Yes, yes. And I usually take it a little bit longer, not very short, more than 12 or 15, so you can be halfway. One thing that I was using in the past, which I stopped doing it, is that I was used to inflate the balloon and then retract the catheter in the ascending aorta to give a kind of a shape to the upper rim. But there are data that you distort the stent by this. And
to move the balloon, but I'm not using it because...
me too, I gave it up. We have seen that the stent now with IVUS and this and that, sometimes it's being distorted. So one straight dilatation over there, and that's it.
With a protruding balloon.
Yeah, with a protruding balloon and a straight option, so keeps the integrity of the stent better. Yeah, exactly. Usually I use a little bit longer balloon there. But this will, of course, be...
Така. Пада ли нещо? This type of maneuver, you mean?
No, we said that we don't do anymore. So just do your dilatation. It's nice that your guiding is going in. First of all, you inflate the balloon and then you do it. But some imaging data shows that it's not a good thing to do. Especially when you're using two big balloons. We had a very recent case that exactly in the scenario that you're doing, that we use a 5.5 balloon and we do this maneuver, and essentially the strand was retracted, and just this part, and it protruded in the aorta, and it created a big issue afterwards to correct the it was not possible We had to mini crush it. So I stopped doing this kind of procedure, especially in calcified vessels. Just go and do high pressure dilatation there. It gives a nice shape as you do. And
we will see the flare with stent boost. Give them the screen. We are thinking now about the stent boost. A little bit slow reaction, but
I think you should go with imaging now. I mean, that you,
Yes.
you dilated the ostium, and yeah, it's
you clearly see the
yeah,
flaring.
very good. Yeah, yeah. Just one. You go to 20 atmospheres over there, and then that's it. Not too much pulling, pushing, and your guiding also went nicely. One of the things that I do while I do this dilatation, and I prefer it, is that I use this dilatation to push the guiding into the left main and keep it stable afterwards. That's engaging, and make sure that you're not really get in and out and understand with the guiding. And whatever else you need to do, just keep the guiding in this position. And I would definitely agree with Dr. Gelev that in this kind of cases, a post-dilatation, kissing post-dilatation, low pressures, 8 atmospheres in the Bose vessel, 3.5 in the LAB, 2.5, 2.0 in the circumflex, just one kissing and final IVUS, and that's it.
It will optimize the shape
okay.
of the bifurcation, the carina and the
Yeah, for the left main, it's a big vessel, and the circumflex is sizable.
Oh,
This is
sorry.
a kind of a 3-0. As you said, there might be more than one struts covering the ostium of this circumflex. And in this kind of case, we know that there is this panus formation on the stents over time that you don't want to. It's better not to have it, because it has been proven that it is being done over time.
It's the result.
Results looks very nice, but we will check with IVUS.
Yeah. We are coming with IVUS. I think if there is no problem in the stent in the middle segment, we will finish the procedure. The patient is stable, the ECG is normal. Let him.
You don't problem now.
No. At last we don't have problems. Okay, we are moving. This is tentacle segment. A lot of calcium around the stents. This is our segment. Okay. Do you see the abs?
yes, we can see the IVUS. In my opinion, the left main is very well expanded, and we have a very good size. What I probably would do is make a post dilation with a non-compliant bone in the AOD.
I think so, yes.
Yes, because
In the previous standard.
no, just at the site of the beginning of the new stand, because there are some, in my view, there are some places where the stand it is. Of course, we should measure, but I think it is above 5.5. But still, there are some places that can be optimized, and we can have a much better position of the stand to the wall. George, what do you think, Didi?
Me too.
With, we post-dilated with 3.5.
Yeah, what was the size of the previous stents in the middle AD?
3.0.
Yeah, at the overlap area and let's say the distal part. So I think the left main is very good, and I think the suggestion of Dr. Gelef is that with a 3.5 balloon, post dilate a little bit the overlapping of the stents, a little bit more distal. There are some points that they need to be further improved over
Yeah,
there. Yeah, the stents are looking circular, but they're
some
undersized.
compression
Yeah,
of
if
the
you
previous
can see
stents.
yeah, if you can see it over there, I think you can go a little bit
triple, yeah.
higher with 3.5 balloon in the middle AD.
And it is very well seen that the stent is just at the ostium. I mean, even several struts are just protruding, and that's a very good position.
Always in the past, the perception of the stents, I don't know, is that they were, with inflation, it's foreshortening. But the point now that we're discussing, you put that there is an elongation of a little bit of the stent of 1 millimeter after dilatation. It came out, and I've been discussing that with the industry and the design of the new stents. So the concept of foreshortening of the stent with the inflation with the new stent design is not a concept anymore. And I have been encountering some issues because I was used to implant the ostial stents exactly, and then by having the marker a little bit protruding into the aorta or whatever, if you want to do ostial left main, or if you want to cover a diagonal, or you do ostial standing of the LAD. And then I found myself protruding too much into the main vessel. And today, exactly as you said, essentially the marker has to be at the point of the carina, and then the stent by expansion covers that. The new stent designs, they have a different also way of how they are behaving during the dilatation of them. We learn a lot about imaging, to be honest. Many things of, especially OCT, that you see the stent architecture well. When you do a lot of imaging, you learn a lot about details that might not be necessarily affecting the outcomes, but they're perfecting the techniques.
I performed the post-dilation on the proximal segment, overlapping at proximal segment. Again, my catheter is not in the place. But now,
Maybe an epicranial. What looks like in the
cranial
middle
is
AD,
better.
what looks like in the middle AD during the acute intervention, the vessel reached its capacity. I mean, if you dilate a little bit harder there, you might rupture it. There was a big chunk of calcium over there. You see,
Yeah.
it looks like a filling defect, which is not intraluminal, but outside the stent. And if you really work much more there, there's a very high risk for rupture and perforation. So I think, in my view, it's an excellent result. I wouldn't do anything more.
What I'm going to do is just to measure and to be sure that we have achieved a good result. Of course, in this extremely calcified vessel, we don't have the perfect and we don't have the same diameters along the vessel, but for sure, if the minimal stented area is above 5.5, we assure that the result is going to be sustained. And of course, we should measure the minimum standard area in the left main.
How long ago the primary PCI was done?
Maybe half a year. 6 months.
Yeah, the reason that I'm asking this question is sometimes, it's not in this case, but you might have suboptimal result in the acute stenting, or you have a stent that it is already implanted, is not very well expanded, and some data show that when the IVL is applied in drug-eluting stents with permanent polymers, and you do IVL over these stents, you are cracking the polymer. Whenever the elution period is finished, that might not be that much relevant. So you do it. It's not according to the guidelines, it's not according to the instructions for use to apply IVL for expanding stents that they have not been properly expanded during the initial implantation, but we're using it off-label. And the suggestion is that at least you do it 3 months later, after essentially the drug elution is finished. So in this case, if for whatever reason is the initial stent hasn't been expanded properly, you can apply IVL.
I think the results is quite.
No, I make the conversation more in general, not in this case.
Yes, we have several cases of unexpanded stents
That
were
it helps.
treated with IVL.
Yes.
But of course, after a period of time. and
Yes,
not really.
to complete the elution.
It's working really
Yes.
amazing. Of course, you cannot see this effect with opening of the lesion and removing the waste of the bone, let's say, because of the stent caging the bone. But after that, with
Post-dilatation.
post-dilatation, you can achieve a very good result
Yes.
at all pressure. So.
So the message is just to wait for the elution period of 3 months to finish, and then you can you can visit these stents.
At
Yeah,
least
there's just
if your result is, let's say, almost
Suboptimal.
acceptable.
Yeah.
If it is critically unacceptable, you should go and, if necessary, treat with a non-compliant bone.
Ivane?
This is final IVUS here.
May I have a
I
suggestion?
think it's obvious the measurements are not necessary.
Okay.
Because there is obviously some here, maybe. Ivana, it's Dobry. Can you place
Hi, Dobry.
the IVUS detector exactly at the place where probably there is a stent malposition, just to see what is the distance between the stent struts and the vessel wall, so we will be able. Because I have a feeling that this, what is looking in the angio as a stent malposition, probably this is the side branch vessel, and it is not very clear from your IVUS tracking. Just
You
behind
mean
the-
here?
No,
here in the previous?
Just back. Go just at the distal left main, so-called. Can you inject some contrast? And some contrast, please.
No.
No, 1 centimeter distally, just to see distally, just to be sure that. Okay, there's some contrast here. Just, and we will see in general what happens. I think it. Yes, there is an aneurysm there.
Aneurysmatic part of the circ. That's why.
Aneurysm,
it's,
yeah.
Yes, and we can see it clearly from the. We think that it's a very good result. Still, you can have the wash shot without the wire, but we are sure that the result is going to be perfect because we have to finish the transmission just to be on time. Thanks, congratulations, great work.
Thank you.